record?
Just let me know. Hey, Katie, are we up and running?
Mm-hmm.
Okay, thank you. Sorry, everyone, for my technical glitches. Hey, it's Susan Stewart here, Executive Director at AHEC West, and I am very happy to introduce our speaker today, Kari Earle. And Kari comes to us as a technical expert lead from JBS International. They are the technical expert or technical assistants, if you're used to that terminology, on our grant for neonatal abstinence syndrome, which may be changing its name to NOWS, neonatal opioid withdrawal syndrome. So we're in flux on that name at this point. But Kari is, she is an expert in her field. She is currently owns her own company. And she's a cohort lead for the grant I just talked about, and she owns her own company. She is very totally, I'm sorry, I'm blanking on my words here, but she is definitely an expert in this category. She owns her own company. It's Reno-based. It's a management consulting firm, and she facilitates coaches, provides capacity building workshops, planning services to a broad range of agencies. In particular, ours is opioid concerns, in particular related to moms. And Kari, so other than my continuing to ramble on about how great you are, go ahead and start talking.
Okay, thanks, Susan. I appreciate that. And Katie, I didn't know if you wanted to say a few things about how just, kind of the logistics part of the webinar.
Sure. A couple of housekeeping items. This is being recorded, and we will send it out to everyone registered after we're done here today. There will be an evaluation link coming to you after we are done. And if you have any questions, please feel free to type them into the chat. I'll be monitoring. And once Kari completes her presentation, we will get to those questions in the chat box. So feel free to type them at any point so you don't forget them. And Kari, I'll turn it over to you.
Thanks, Katie. Hi, everybody. It's great to be here with you today to talk about what I feel is one of the most important aspects of care around perinatal care, which is the 4th trimester. So we're going to just be talking today about some different aspects of that. And I'm going to actually do a little moving around because these Zoom cues are blocking my screen. There we go. So today we're going to talk, I'm going to just give you a quick overview of some current trends we're seeing in the data around the population of pregnant and birthing people with substance use disorders. We're going to talk about some of the barriers that they experience in accessing treatment and recovery support. We're going to talk about ways to change that and really start taking a more dignity-centered approach to care, especially for those families that are at the intersection of multiple systems. And finally, I'm just going to highlight a few different resource and policy levers that are available to you as a community to address this perhaps in a more systemic way. So let's just start by talking about the current landscape. We know right now in America that moms are not okay. We are experiencing high rates of maternal morbidity and mortality. And right now, the mental health conditions, including SUDs, suicides, overdoses, are the leading cause of preventable maternal deaths in the United States. So we have a lot of room for improvement here. And in the face of this bad news, the good news is that there are things we can do to improve these dire outcomes for maternal and child health. I think it's really important to note that the rate of drug-related deaths, suicide, and homicide accounted for 1 in 5 or 22% of pregnancy-associated deaths. So that's really startling to think about, especially when you think about that being the data pre-pandemic. Post-pandemic, the increase it has been even more stark. There's some converging risk factors, kind of the perfect storm here, that lead to some of the data that I just shared with you. So when we talk about that statistic doubling from 1 in 5 to now potentially 2 to 3 in 5 women who suffer from maternal mental health disorders, we also know that women are most at risk of developing a substance use disorder when they are in their reproductive years. So 18 to 44 years is how that's defined. And so this creates that vulnerability of pregnancy colliding with a substance use disorder. And on top of that, we also know that there are some substances that make it harder to detect pregnancy because periods maybe don't happen regularly, or there's other reasons where a pregnancy is undetected and unknown. People think they can't get pregnant on using certain substances. So that leads to this high unintended pregnancy rate among women of childbearing age that do have substance use disorders. About 80% of those pregnancies are unintended. And of course, that comes with massive consequences for both mother and infant. There's some additional risk factors to consider too, as we look at improving services for this population. So there's a high correlation with trauma, both trauma that is occurring, in the present through intimate partner violence, but also historical trauma, childhood trauma from physical, sexual abuse and neglect. Excuse me. There's a lot of stigma around this population. We're going to talk a lot more about that because that is one of the levers that we're going to discuss in more depth. But the stigma comes from everywhere, including self-stigma, which prevents women a lot of times from entering care or seeking help. And then we know that there are a higher rate of pregnancy complications associated with substance use in pregnancy. Some of them are listed on the screen. A huge factor here that leads to poor outcomes is poor prenatal care. So there is a big correlation between a pregnant woman who is using substances during pregnancy, her fear of having a punitive response from either child welfare or the criminal justice system or the courts, and or from healthcare providers themselves, that leads to hiding and reluctance to come into care. And finally, poverty and homelessness, lack of social supports, all those social determinants of health that we have been increasingly talking about and figuring out how to incorporate into our clinical practice and healthcare practice models are main drivers for some of those poor outcomes. So I said we're going to talk a little bit more about stigma, and starting here, I think one of the things that we don't always fully recognize is the degree to which women are stigmatized in multiple of their roles, their gender roles, their marital status, their sexuality. Race, ethnicity certainly is a huge factor. Whether or not they've had involvement in the criminal justice system, they have mental health issues, if they're poor. So when those all converge in the context of pregnancy, women face a huge punitive response in our society. And that does create these huge barriers to accessing care. And we also know that these punitive practices are more likely to affect poor women and women of color, and women who use the public health and social services system. So they're subject to more increased surveillance, whether that's through drug testing or oversight from the child welfare system or parole and probation. They're at increased likelihood of being reported to authorities So it's a high climb and a very vulnerable time. And I know right now we're talking about pregnancy, and the focus of this webinar is that fourth trimester, but I think it's important to understand the journey, the perinatal journey, so that we do recognize that once that infant is delivered and we're in the postpartum period, there's a lot of trauma even potentially experienced by that woman leading up to that delivery. We also know that postpartum is, which we refer to as the fourth trimester, is a uniquely vulnerable time. So we talk a lot about pregnancy as this window of opportunity, because there's a higher level of motivation. There's a concern for, even if I'm not going to take care of myself, I'm going to take care of this life growing inside of me. I'm going to do it differently this time if there's happened to have been previous pregnancies. So that all creates an opportunity for improved engagement in treatment and healthcare support and recovery support. And then we look at the postpartum period, and depending on what's happening and whether or not mom was engaged in any kind of supportive services or prenatal care earlier in her pregnancy versus later, that comes with a cascade of reactions once she gets to the hospital and delivers. And that could also then trigger some additional stress and trauma responses. For instance, if her child gets removed from her care in the hospital, that's going to be its own trauma. And then even if that dyad, that mom and baby dyad, gets to stay together, there is all of this increased stress around being a new parent, sleep deprivation, how to care for this newborn. If the newborn is exhibiting any kind of symptoms around that substance exposure, that's its own level of stress. And everyone in this webinar that has had children also understands the increased financial demands, and then if there's limited social supports and resource availability in the context of all of that additional stress, you can see why that rate of maternal mental health issues postpartum is so high. Whoops. So I'm going to move from kind of this broad context to talk a little bit more about specific barriers, both individual, cultural, and systemic, that face this population. And I want to start with this quote from Melanie Goodchild. She's a member of the Ojibwe tribe and founder and co-director of the Turtle Island Institute. And I was listening to her, I think it was a year or so ago, and it just, when she said, we've created these systems where those most at risk are suffering the most, that resonated with me, because I think when we are here as helpers, we often are blind to some of the systemic ways that we make it even more challenging rather than less challenging for the people that are in need of care. And for rural populations, this is especially the case. So access to care for women in rural counties with substance use disorder who see themselves as needing treatment and are seeking treatment, it's 90% lower than people, the counterparts in urban counties, 90%. So you're looking at the majority of the population having difficulty trying to enter care, even if they are actively seeking help. 66% of women with substance use disorder who are pregnant say that pregnancy is a barrier to entering treatment. And we know this to be true just even anecdotally. I have personally experienced difficult times getting women access to care in community-based treatment programs who are afraid that they are not able to handle a high-risk pregnancy, and so they deny treatment or deny admission. We also know that receiving medication-assisted treatment, or MOUD, medication for an opioid use disorder, doesn't happen with pregnant women as much as it should, even though it's the evidence-based approach to treatment. 44%, almost half of the population, don't have access. And then finally looking at, I think there's about 80% of Medicaid births cover, let me just rephrase that. The population of pregnant women with substance use disorder, there's about 80% of them that are covered by Medicaid. So there's a pretty high correlation with lower income individuals. And of those, only 20% say that they were able to receive treatment in a healthcare setting in the previous year. And this is from 2020 data. This creates some huge health disparities, and those are contributing factors to the data that we've already discussed. And when we talk about the inequities that people who are either a racial minority or are living in poverty, have other economic inequities, the fact that they're more likely to experience maternal mental health conditions is associated with the mistrust that they experience of healthcare social service systems, the trauma that we've already talked about, which also results in a loss of their own agency, both personal and at the collective level. What, you know, if we're talking about Indigenous women, especially, that's true. We know that for Black mothers, there's a much higher rate of maternal mental health issues and maternal morbidity and mortality than there is for their white counterparts. There are additional layers of stigma that come along with some of those characteristics. And there's also some cultural mistrust around medication. So not only are there system influences and cultural influences, but those individual influences that present those additional barriers. And it's important to look at some of the specific needs and challenges that this population faces. They are more difficult to engage, especially if they have children in their care, because finding safe care for their children so that they can access healthcare and treatment is often impossible, especially in rural communities where there may not be as many childcare resources or transportation resources. You can see that on the screen. A couple of bullets down, transportation and housing are consistently identified as the biggest barriers to care by the grantees that are in the cohort with you all. And then finally, child welfare timeframes make it a lot more challenging. Back in the mid-90s, the Adoption of Safe Families Act was passed, which created a much shorter time frame for courts and child welfare to make permanency decisions. And we've known for now several decades that the clash between those shorter timeframes to achieve permanency in child welfare are at odds with the longer timeframes for building solid recovery. So we've done a lot of things to try to address this through specialty courts, family courts, but it continues to be a problem for the vast majority of women who are involved in the child welfare system. So I mentioned that I would talk more about stigma at each of these levels, and I think this probably doesn't come to a surprise for any of you that are working directly with this population as clinicians, but in addition to that external stigma that they experience from the community and providers and system professionals, there is an eternal stigma and shame, being perceived as a bad mom. And there's also stigma around disclosing substance use during pregnancy because of the anticipated discrimination and bias that they might experience. At the cultural level, and I've addressed some of these, so I'll move through this pretty fast because I do want to make sure we have lots of time for questions at the end. But it's important to understand that people come from different cultures. Sometimes it's not always clear what culture someone brings with them into services. And so through your assessment processes and ongoing treatment planning, you eventually learn, but we often don't understand the degree to which some of that history impacts care access. The Indigenous women have a long history of forced removals from federal government, forcing children into boarding schools and has created a family separation that has had an intergenerational impact on trauma. And that does create and contribute to that mistrust, and it's frankly very validly placed. The drug testing that has happened without consent and continues honestly to happen without consent. I'm always struck by how many hospital systems will give a nod to drug testing, saying that they get consent, but that consent is buried in a raft of papers that most women are not oriented to or have explained to them. So it's not informed consent. And then we know that positive toxicology screen usually leads to a punitive response unless communities have put something in place to avoid that. At the systems level, there are a number of barriers that create problems, creating the kind of continuum of care that can better serve this population than the ones that we currently have in place. There's a lot of issues around reimbursement and financing. We won't go into that a lot, but that could be its own webinar. There are a number of service gaps. I mean, I talked earlier about how difficult it is for women to access treatment because that treatment either isn't available in their community or isn't a family-oriented service. We have massive workforce limitations. Again, that's been a huge challenge. We are seeing maternal and child health deserts all over the place, not just in rural communities, but in urban ones as well in this country. I mean, we're seeing hospitals close, and I recently read, I think it was in Connecticut, the hospital tried to close their maternal and child health department, and we're not allowed to. So they're in a fight now with the federal government. They're trying to figure out how to make something happen that they can't make happen from a financial sustainability standpoint. And so we're in a really difficult situation around workforce. And then there's a lot of barriers to just working together, collaboration, competing priorities across agency. We know that pandemic has done a real number, especially on departments of health who've had a difficult time, being able to engage in any kind of collaborative work because their heads have just been down and working on COVID issues and vaccine issues. But beyond the competing priorities, there are problems around information and data sharing. People either perceive that they're unable to share information, or perhaps they're unwilling to share information for reasons that may have to do with competition, or they may have to do with mistrust of one another. And conflicting values around this population is something that I think we don't always talk about enough. When we do come to the table together to collaborate, we don't always identify that different people sitting around the table have a different lens. For instance, child welfare is going to come in with the priority on the child outcomes. Treatment providers are going to come in with a priority on maternal outcomes. We don't always connect the dots between that mother and baby dyad the way that we should as we move through collaborative values discussions. And then I've already talked a little bit about culture and the importance of being responsive to that. So again, all of those things make this an even steeper climb. How do we move forward? Any discussion about the way forward has to be honest about the past. So again, I found this a great quote that just is important to acknowledge the how we got here, so that when we think about changing our strategy, we can do it in a way that is informed by history and informed by what hasn't worked. And to do that, we really do need to start disrupting the way that we are coming about these substandard outcomes. And that, in my view, requires understanding substance use disorder as a healthcare condition to be treated rather than a root cause to be punished. And that has implications through policy and practice at every level of almost every organization that serves this population. And that isn't an easy thing to do. It means looking at our values, our policies, our practices, and really taking a microscope into what needs to change. what's working and what needs to change. And if something is in place, for instance, in a policy, is it driven by the current evidence base that we are aware of? Or is it driven by some historical, well, we've always done it this way? And chances are, at least this was my experience running an agency in Reno, Nevada, where we were providing family-centered care on a campus setting. We had a lot of really kind of leading edge strategies in place, but it took a lot of work to untangle some of the old school policies that we had that frankly removed women's agency because we had rules in place that were for the convenience of staff, not for the wellness of the patients that we were caring for. And so we had to turn the corner on that. And when we did, lo and behold, our outcomes did start to improve. We also need to make sure that our work is family-centered. And I'm increasingly aware of, I mean, we've been talking a lot for as long as I've been in this field, which is over 30 years, about the need to involve not just mom, but dad or whoever the involved partners and other family members are in the recovery and wellness approach that we take. And yet, here we are still not doing a very good job of that, particularly in community-based programs that are not necessarily designed to be gender responsive. We don't often, when we're serving adult men, look at them in the context of who they are as a family and who their family is. And yet, when we do that, we build the support for whatever that family unit looks like to heal together in a much more sustainable way. The thing that I think is also important to note, as we've talked about how challenged this population is for all the vulnerabilities that they experience and some of the trauma histories they have, this is an incredibly resilient population, especially women of color. And so we really need to take that in and design programs that are based on the strength and resiliency of this population and not on their weaknesses. And that again is a paradigm shift that is often harder to make than we want to admit. So I just want to kind of encourage and challenge you with that as we continue to talk through these other slides and get to the question part, but to think about how that might look in the work that you do. Oops. So there's some key ways to support postpartum mothers, and it starts with understanding some of the guilt, shame, and stigma that they've experienced, recognizing and addressing the anxiety and mood disorders, which means a screening process has to be in place at regular intervals, both through pregnancy and through the postpartum period, at least up to a year. We have data to show that the highest rate of mortality, whether it's from suicide, overdose, or another reason, happens about 8 months postpartum. And yet often our practices up until recently have really, I mean, Medicaid only provides 60 days of postpartum coverage. That has now changed, and we'll talk a little bit about that at the end when we talk about policy levers. But we as a society have taken a long time to understand the need for supports and screening and identification of issues and addressing those issues way longer than just a couple of months after delivery. We need to make sure that services are available and accessible. So like I mentioned earlier with some of we have a treatment program for that, but are women experiencing difficulty accessing it even if it exists? Making sure that mother-baby dyad is honored and I should say this is allow mothers and children or parents and children to remain together, but keeping that family unit together is associated with much stronger outcomes. And making sure that we provide supports for parenting and recovery. Many women with substance use disorders, especially if it's a long history, don't really have any good parenting models to work with. So providing that evidence-based parenting support is another really important way to support postpartum women. So where do you start? And as I designed this slide, I thought it was important to think about the three key pieces of success, which is about access, like we've discussed, retention, so not just access into care, but the longer that a woman stays in care, we know the higher the rate of success in recovery is. And then building that trust from the start, building that therapeutic engagement. So this is by no means a full list of high impact solutions, but this is a good place to think about starting. Selecting one or more of these as a way to, start turning the tide. And I'm not going to go through all of them because we don't have time, but I did want to put this list up there. You guys will have access to these slides after the webinar. And if you and my contact information is on here. So if there's anything you want to know more about with these models or others, please feel free to reach out. I am going to talk, though, about evidence-based outreach strategies because I hear all over the place from across the country that outreach is one of the most challenging issues when this is a population that hides and is reluctant to enter care for the reasons we've already discussed. So there are some things, though, that are, and you may already, in fact, I would suspect that you've already tried some, if not all of these, and I would hope that when we get to Q&A, I welcome you to share what's been successful for you. You all are experts. So this is not just about one person trying to tell a group of people what works best, but about sharing that and kind of cross-pollinating that knowledge of what works well, especially in your community. Working, though, with some of the other agencies can be a really important, and by other agencies, harm reduction agencies, crisis intervention. Those are just a couple of ideas, but there are some possible ways to go about this. For instance, we have one grantee in this cohort that is exploring doing pre-treatment intervention groups in the OB office. So having just a support group for women who have identified as using substances in their pregnancy, maybe not as having a substance use disorder, but providing a place for them to talk to their peers in a supported group that is not in a treatment setting can be a really effective way to keep them engaged or get them engaged. Making sure that we're using evidence-based screening and assessment tools that are designed for this population are important because there are some different dynamics that need to be assessed and addressed than for men. There's also intensive case management and that goes beyond outreach. But when we look at things like home visiting services, where this is already occurring, that can be an opportunity to reach out and engage in additional treatment supports. So things, home-based and mobile services are very effective. Peer supports we know work. And then finally, timely appointment scheduling, making sure that when she's ready or when the family is ready, there is a place for them and they don't have to wait around. I see that way too often, and I have a feeling you all have your stories around that as well. When we talk about screening, it's important to differentiate between toxicology screening and brief verbal screens. They're part of an expert's process. So screening, brief intervention, and referral to treatment. And again, can provide plenty more on SBIRT. I suspect that most everybody on this call is familiar with SBIRT, uses SBIRT, I hope. But sometimes we don't identify all the different places that it doesn't have to be necessarily in a healthcare setting. It could be in a school setting. But again, just making sure that it's a universal approach when we do selective screening based on quote unquote risk factors, it tends to skew poorly for women, low-income women and women of color. And that's where the need for that universal approach, making sure we're screening every woman who comes into care, is the evidence approach, based approach that's recommended by ACOG. There are some barriers to screening, so SBIRT is one of those things that we've had around for a while, and it's still had a relatively low uptake, especially for this population. And that's for a number of reasons. But there are reasons that we can address. So low confidence in, if I'm a physician, I may not have training in SBIRT. So I may not have enough knowledge about substance use in pregnancy or substance use just in general to feel like I can effectively intervene. I may be very concerned about asking that question in a way that potentially can harm the trust that I'm building with my patient. I may have reimbursement concerns. I don't want to make her ashamed, so I may want to avoid a difficult conversation out of a true concern about creating or inducing shame. I may not have enough time. I may not know where to send her if she did tell me she was using substances. And just again, that whole ability, we assume a lot of times that our healthcare providers are experts in everything, and that's just not true. So that speaks to the collaboration we're going to talk about in a bit. Stigma, stigma, stigma. I mean, I can't iterate this enough. If we don't address stigma through some of these different concrete strategies, we aren't ever going to move the needle on these outcomes, because this is a population more than any other that experiences stigma more severely than any other, both in the context of substance use and both in the context of pregnancy. So I already mentioned that whole notion of looking at our policies and practice and engaging, with one another in what we believe and identifying where we disagree so that we can work on how to resolve that through a combination of trust building and relationship building, but also that education and training piece. And then moving that into the way that we practice and using person-centered language and in a dignity-centered approach. I had a colleague recently talk about, instead of being mandatory reporters, we should see ourselves as mandatory supporters. And so I loved it. I stole it for this slide. And I think that if you walk away with nothing else today but that, then I'm going to consider it successful, because I really do think that is part of our paradigm shift and understanding, from a collective level, how do we as a community become mandatory supporters for the people that are the most vulnerable in our community, rather than drive them further into despair. Not going to read all of the slide to you, but there are a lot of different ways to do that, both directly if you are a clinician, but also just as a member of your community. And then looking at what else is in the community. Not every community has all of these things, but probably every community has some of these things, and making sure that they're on your radar, so that not only can you facilitate linkage to additional supports that are gonna that are available to undergird this family as they're going through care and moving into hopefully very healthy parenting and family wellness and child safety. There are some important connections to make sure you're making. So I'm going to get to the last part of this, and then we're going to move on into questions. But I really want to emphasize that the partnerships that can help build a better continuum of care. And sometimes, and I know you all have done needs assessments with whether it is through a mandated funder who is requiring you to do needs assessment every 3 years or whatever it is, or whether it's for a discretionary funding opportunity but you do, through those needs assessments, have an opportunity to kind of take stock. And related to this population or any other, it's always good to ask, how do the people that you are talking about serving experience your current system? And how do you actually access them directly through involvement, engagement, to provide, kind of their meaningful inclusion in the system change process? That could be making sure that they're represented on advisory committees, making sure that you are polling them for feedback through focus groups or key informant interviews or other. There's a lot of different ways to make sure that the people that you're talking about serving are actually actively involved in informing the change that you're seeking to make. What do you want your continuum to include? And what actions can you take to move in that direction? What challenges do you need to come, whether that's a funding issue, whether that's a capacity or a workforce capacity issue, whether it's data that you're seeking and don't have. I mean, so you can see through this list, I won't keep reading through all of it, that there are a lot of different places you could start. And these are all things that are important to consider. One of the things that I also don't think people necessarily always connect the dots between are the natural change champions in your community. There are always people in a given community that have already established trust with the people that you're looking to serve. That could be the worker at the food pantry. That could be somebody in the WIC office. That could be a faith leader. Making sure you know who those people are and are also engaging them in supporting your change. There are also a lot of leveraging opportunities beyond funding. Certainly funding is an important piece of this, but there are other things that are available in terms of resources to support you in this work and in making a change, whether that is, you can see in that little graphic there, some potential ideas, and a seat at the table is at the middle, because if you are involved in the place where decisions are being made about resource allocations, policy decisions, then you're much more likely to influence that lever and be able to pull it a little bit easier. There's a lot of different places where these tables exist, and some of them are listed here on the side. Again, not a exhaustive list, but a good place to start, and making sure that you do recognize that at different levels there are different places to interact. I know that there are a lot of disconnects that often occur between state agencies and rural communities, that rural communities often feel kind of either ignored or left behind or not considered as some of the state level resource and policy conversations are happening. Sometimes that's true even if you're at the table. So it can be very frustrating, but making sure that wherever you can, you're inserting yourself into those conversations, and kind of like a dog with a bone, don't let them forget about what the needs are in your community, because they're likely to be different from other communities in the state. And at the national level, there are a lot of options. Sometimes they don't feel super accessible, but I'm going to, kind of highlight a couple of things that are going on nationally that you might want to pay attention to, because those resources will eventually trickle down. And I talked earlier about what community-based supports there are for you to think about, but there's also just who else is serving this population. So that is an additional, it's an overlapping list, but it's an additional place for you to look for support. And, legal aid, frankly, is one of those that doesn't often come up into the realm of consortium participation, but it absolutely should. There's a lot that they know and can do to support and advocate for this population in a way that is unique. Others on there as well, your managed care organizations are often, they have high risk pregnancy case management services. Most managed care organizations do, but they often don't intersect with community-based services and supports that they don't reimburse. So there is usually a disconnect there, but that doesn't have to be the case. When I worked in communities to facilitate kind of cross systems change initiatives, my experience has been, I've been delighted at how willing managed care organizations are to come to the table, because they have, even if they may not be reimbursing or managing that particular beneficiary, they're invested in an overall community health and wellness because it contributes to their bottom line. When we talk about partnering, we always want to start with the pregnant person and her family. So that means, and I'll talk a little bit more about this, but I know we're running a little bit short on time, so I'm going to move fast. But that means, engaging early, making sure to do the warm handoffs across the perinatal care from OBG to pediatrician or family practice, wherever that ongoing care is provided. We know that those practices can be siloed. And so to the degree that we can improve those linkages, we know that a lot of women post-delivery don't access their own care, but they will make sure that their child gets to care. So that pediatrician becomes a real linchpin in the process. Of course, making sure that you're linking and partnering with treatment providers, both medication-assisted providers and community-based treatment options, faith-based organizations, and other key organizations. I've talked a lot about this slide, so I'm going to move past it. But I think I've covered pretty much everything that's on here. And same here. So that warm handoff, bridging across care. And you'll see this slide, but this to me, in some ways, this is an oh duh, and I almost took the slide out because it felt like it was a little bit lectury. But I think it's also kind of good to put up in front why partnering improves system outcomes. And it's for these reasons. It's more cost effective. We maximize resources. We reduce redundancies. And we can streamline the experience for the patient. I mentioned that I was gonna highlight for you some policy levers that are going on at the federal level. So, through when the American Rescue Plan Act passed, that gave states the opportunity to extend postpartum coverage to 12 months. This is a huge deal. I think it's just rolling out, but I fully expect that we'll start seeing the data that links to better outcomes here for the states that are adopting it. Not every state yet is. There are a lot of levers in Medicaid, the 1115 waivers. I talked about managed care organizations, partnering with them, expanding coverage, making sure that your Medicaid, your state, just that you're tracking what your Medicaid policy is in Maryland. And then the White House just last week released the maternal health blueprint. I think it was last week. That is this whole of government approach that has 5 priorities they outline. So I would encourage you to kind of take a look at that, and I can send you that link and follow up, or you can Google it. It'll come right up. And there's a number of federal initiatives and legislation that are currently being considered related to maternal and child health. So maternal mental health, the Into the Light Act, reauthorizes and expands existing programs. This is, I believe, the act that covered the maternal mental health hotline. There's also a Moms Matter Act that addresses health equity, mental health equity. The Triumph Act improves at the federal level coordination around maternal mental health supports. This is the hotline that just went live in May. It connects with the 988 hotline and coordinates. So I wanted to make sure you knew about this. But there are a lot of things that are happening in this space. And so it's a good time to be working and addressing, the kind of change that's needed. I'm going to stop here and open it up for your questions and your own insights.
Kari, I want to thank you. This is most informative. I particularly, and I threw it in the chat, really like the reminders of building trust first. And it's nice to hear what's coming down the pike. Hey, Katie, and anyone else who has questions, please chime in.
Yeah, and if there's anybody participating that can share things that have worked in your workspace, I really do encourage you to share those.
I'd also like to add, we had a question early on from Kathy about receiving the presentation slides at the end. And yes, Kathy, we will get that information out to you. We also will post the recording on our YouTube, and we'll make sure to send the YouTube link out to everyone.
And I thought, well, that's weird. I'll make sure that the slide version that you have has my contact information on it.
Well, I know I lost connection during the presentation and then came back in, and maybe some others did too, but Kari, thank you so much.
You're welcome. Thanks.
A
for
wealth of
having me.
information. Yeah, as usual.
It's a lot to cover.
It's a lot. It's a lot. And thank you for keeping up on it.
Yeah, I do see there's a question. How do we as organizations realize that recovery isn't the same as abstinence? And how can we support that without further increasing shame and stigma? I love this question, so thank you for asking it. So I didn't talk as much as I would like to about the importance of harm reduction. And understanding the different pathways to recovery. And so I'm hoping I'm getting at what's behind your question. What I see in the question is that just stopping use isn't necessarily recovery in the sense of changing a thought or behavior pattern, or putting things in place in your life that are going to, whether that is removing, being removed from a unhealthy social situation or relationship or living situation. So you're right. There's a lot of aspects of recovery that are way beyond just whether or not somebody is using. And Susan, I see you're wanting to weigh in on that, and so I would love for you to do that as well. But I wanted to also just mention the piece about different pathways to recovery, meaning that also abstinence is not a necessary element of recovery. So someone can be in recovery and have remission into use, and that doesn't negate the recovery. It just means they had a remission into use, and just like with any other health condition. But go ahead, Susan, were you gonna weigh in on this?
The only thing I have to weigh in on it is that if we park our judgment, people have different pathways to recovery. It's as simple as that. And through the work that I've been doing in the last few years, recent years at AHEC West, wow, have I learned a lot. And it's helped me change my own perspective. So, yeah.
Yeah, that's good growth. And me too. I feel like I'm always changing my own perspective. The more that I understand and learn, the more I drop old beliefs about a lot of things. And the piece, and I like that you brought up in the question about without further increasing shame and stigma. I think that, to Susan's point, gets to accepting someone, not only accepting someone where they are, and I know that that's a kind of an overused phrase, but it's a very person and dignity-centered approach to think about who's in front of you rather than what we may, kind of come to that conversation with in terms of that bias or potential for judgment. And could be based on fear. It could be, depending on the circumstances. I've talked to providers who, if dad is coming in all tatted and has got the face tattoos and is scary looking, chances are we're going to have a stigmatizing response when truthfully he could just be as scared as anybody about what's going to happen next and needs to have that handheld. So there's a lot of judgment that we just trigger judgments, I think, that we make. And so being able to think about, what does it mean when I say I'm going to address this person as an individual where they are, without increasing their shame and stigma. Attending to both of those things is super important, and it requires kind of changing that community paradigm to be more supportive, that mandatory supporter.
Thank you, Kari. I might have to confess that I might have been one of those judgmental pregnant moms, you know, back in the 80s. Not I might have been, I'm sure I was. Yeah, thank you so much, Kari. Katie, is there anything else?
I would just like to note that I did put our evaluation link in the chat. So make sure before you drop off at 1 to please click on the link. That helps us. And if you miss the link, we will send it out with the presentation.
Thank you, everyone, especially Kari.
Thank you.
Thanks, everyone. Thanks, Kari.
Bye.
Bye-bye.